Good morning. I would like to talk about facial reconstruction and restoration by transplantation. My name is Bohdan Pomahac, and I'm in Boston. So complex facial injuries are very difficult to manage, especially in the central part of the face. This woman was attacked by a dog, and after basic debridement and closure, she was left with significant upper lip and nasal defects. After multiple operations that included radial forearm flap, forehead flap, cartilage grafting, and so forth, she ended up looking reasonably normal, but definitely not normal. Similarly, large cancers in the midface are pretty much converted into wound closure rather than true reconstruction, as the defect created by removal of the central facial features cannot be truly reconstructed. This woman ends up looking extremely abnormal, but at least the wound is closed and cancer removed. It was about 3-4 years ago when I visited the National Museum of Health and Medicine that made me realize that compared to 100 years ago, we haven't made significant progress. Sir Harold Gillies has back then performed multiple walking flaps to cover midfacial defects with tissues that really don't belong to the face, but allow and accomplish closure of the wound. And even today, even though it takes only one instead of multiple operations, we're still left with essentially similar results: closure of a wound, but not really fundamentally, markedly, qualitatively improved outcome. And my hope was that we could actually come up with something different. Obviously, there are alternatives such as facial prosthesis that are currently being used, and some of them can look fairly realistic, but patients in general don't like them, and they require care and do not move or integrate. There are some conventional reconstruction techniques that some of our colleagues have mastered, and the results can be quite impressive. Nonetheless, tissue engineering and bioprinting is still pretty far. So transplantation is really the way to restore the complex facial defects that otherwise would be impossible to restore. This is an example of one of our transplants, upper and lower jaw with overlying soft tissues. And you can see, following revascularization, how the blood is reperfusing otherwise dead appearing face coming alive in front of your eyes. This unit, as I'll explain in a moment, contains all the functional elements that really patient needs in order to reintegrate this unit into their face and function. Immune suppression is unfortunately the necessary requirement for the patients to maintain this foreign tissue, and we have had tremendous help from our transplant colleagues, and especially Dr. Tullius, who designed our protocol for VCA. It's not dissimilar from what we would expect in solid organ transplants, although the induction with thymoglobulin is a bit longer. But in general, the patients end up on triple therapy, including calcineurin inhibitor, steroid, and Cellcept or mycophenolic acid. At the very beginning, when we started doing transplants, we thought of what would be the fundamental principles that should apply to this type of operation. And it to us appeared critical that this remains safe. The patients would have salvage options should the face fail, especially in the younger patients. It should be technically feasible, which means that it cannot be overly complex by including a variety of facial vessels that may provide blood flow to the central part of the face. Functional units in the patients, in the recipient's face, should be preserved, and the new transplant should really be integrated into the facial function of the recipient. And all of that ideally would be performed with the most functional and aesthetic integration. At the same time, we wanted to investigate the outcomes of sentinel allograft flap, which was used in some cases as a functional release for contractures, in some cases only as a monitoring island. And this flap, obviously, should it be concordant with rejection of the face, would be an important monitoring device for the patient and for the clinicians, especially in the future when the facial units that are transplanted may become smaller. We have hypothesized early on and then subsequently proven that full face all the way to the posterior parietal region of the scalp, including the entire face down to the neck tissues all the way to the clavicle, could be successfully transplanted on facial artery, despite the fact that the actual territory that you see in the bottom right picture is rather small. Face, fortunately, has a fairly extensive network of anastomoses and quite well. This hypothesis resulted in a successful series of transplants and publication of the novel technique back in 2012, for which we got the Barrett Brown Award, a prestigious award by the American Association of Plastic Surgery for the best paper of the year. For the actual preparation of the surgery, radiology has proven to be extremely important. The patients often have underlying abnormalities of skeleton that are not easily visible, and probably even more importantly, they often have depleted vessels in the neck that make it very difficult for anastomosis. Getting the proper imaging has allowed us to understand that some of the vessels may not be usable and prepare potential cephalic or even greater saphenous veins for harvest of vein grafts whenever needed. With the novel techniques and the collaboration of our colleagues from radiology under leadership of Dr. Rybicki, you can see that the novel scans not only provide the subtraction of various types of tissues, you can visualize the surface, but you can also visualize only the bones or overlay the vessels. We've been able to have a truly remarkable pre-operative planning. Our first patient was transplanted in 2009 and had an extensive defect of his midface. And for each of the patient, we have pretty much developed the same preparation manual, not as nice and graphic as it is for this presentation, but essentially a list of items that the facial allograft must include. Due to this type of defect, we were anticipating to need both facial nerve branches going to the upper lip and cheeks, as well as sensory nerves that provide sensation to the skin, as well as buccal nerves for sensation of the mucosa. And the plan was to connect both of these pedicles, facial arteries on each side into either external carotid or facial artery. This is the patient in 2016. I will show you a little bit later his most recent photographs. Our second patient has suffered from high voltage injury and lost entirely his soft tissues of the face. You can see at the time of reconstruction performed in Texas, he essentially had exposed bone of the entire face, no teeth, and unfortunately lost his vision as well. The allograft therefore included the entire extent of facial musculature, including all the branches of the facial nerve. And on the left side, due to the more extensive defect of soft tissues, we included the parotid gland, and that has led to better symmetry. In general, though, we do not include glands or parotid glands and try to dissect the facial nerve through the parotid to get adequate length and avoid nerve grafts. But we do not want to either perform superficial parotidectomy on the recipient or cause unnecessary bulk following the transplant. This is the patient following his transplantation several years later. Our third patient sustained a burn to his face with loss of tissues of his nose and upper and lower lip. Because the remaining musculature of the face functioned, we included only nerve branches going to the upper and lower lip. And in a similar fashion, all the sensory nerves, supraorbital, infraorbital, and mental nerves. This is the patient that tells us now, almost 10 years after the surgery, that his sensation is normal and virtually normal, and certainly better than any time before with skin graft that he had prior to the transplantation. You can see on the left side the preoperative picture following closure of the injuries, and on the right side the post-transplant photograph. In his case, we left the eyelid apparatus intact, but we overlaid a skin of the allograft so it looks more natural and blends in seamlessly. Our fourth patient was attacked by a chimpanzee and sustained extensive midfacial injuries that included the entire upper jaw and all the soft tissues of the face. Unfortunately, she also lost both of her eyes. The allograft was designed in a similar fashion as our first full face transplantation, but in addition, we included maxilla. It means that all the sensory nerves, facial nerves, and upper jaw were included. Unfortunately, as you can see here, the damage to the maxilla was so extensive that we couldn't find infraorbital nerves, and therefore we could only connect supraorbital and mental nerves for sensation. This is her 8 years after surgery. I should also say that some of the patients are now followed locally, so I don't have the very recent pictures, but nonetheless, all of them are in touch and monitored. Our fifth patient is probably most complex immunologically. She sustained extensive burn when her estranged ex-husband dosed her with industrial strength lye and caused 80% total body surface area burn. She had enormous contractures of her neck as well as face. The left side of the face was not functioning nowhere near as well as the right. And so the plan was to release her contractures, provide extensive soft tissue down to the clavicles to alleviate some of her pain, and provide obviously more facial nerve branches on the left side of the more damaged side of the face, and all the sensory nerves connection as well. This patient was on 350 milligrams of oxycodone prior to transplant, an enormous dose that barely kept her comfortable due to the contractures. Following surgery, we were able to completely remove her off the pain medications within a year, and she has been, until recent events, doing really well. Our patient number 6 and 7 actually are similar gunshot wounds that resulted in extensive loss of upper and lower jaw, requiring transplant of the upper and lower jaw in one sort of block. Similarly here, we only integrated what was missing in order to not cause potentially greater damage should this part fail. Facial nerve branches are included for upper and lower lip, and sensory branches included for the mental nerve and infraorbital nerve. This is the patient 4 years post-operatively. He continues to do very well. He's back at work and has had virtually no issues following the first year after transplant. Patient number 7, similar scenario, extensive tissue defect of the midface, pretty much the identical design of the operation with a result 4 years after the surgery. Patient number 8, similar upper and lower jaw transplant. Unfortunately, in his case, we didn't notice that the zygoma on the right side had a malunion. So at the time of surgery, we used computer navigation to inset exactly the facial unit of the upper and lower jaw. But unfortunately, that caused some displacement of the unstable zygoma, which was later repaired, and the patient is due for follow-up. And finally, our last patient who had extensive burn of his face, lost both upper and lower lip and part of the nose, who underwent full face transplant approximately 9 months ago. So what are really the outcomes? That's probably the most important. These immediate surgical results are certainly remarkable, and in many ways one could say stunning, but the most important is what the patients are going through otherwise. So first we looked at the utility of sentinel flaps and found that in the lower grades of rejection, the rejection did not present the same way in the face and in the sentinel flap, but the higher the grade of rejection, the more concordance there was. So at the most important grade 3 rejections, we really saw that both the allograft sentinel flap as well as the face really behaved similarly. In terms of skeletal reconstruction, the first patients have undergone only upper jaw transplantation, and we saw certain issues related to mismatch of the upper and lower jaw. This is patient number 1. This is patient number 3. And you can see that there is a little bit of overprojection of the maxilla, and that's in part inevitable because the lower person. Nonetheless, we were able to achieve functional inclusion in all patients. We've also looked at airway volume and flow and found that nasal cavities and volumes of nasal and oral cavities have increased over the after the transplantation, and nasal mucosa has been producing mucin, essentially functioning normally. Sensation continues to improve, and you can see from this sort of rather crude graph where white areas are no sensation, yellow 15 millimeter 2-point discrimination, orange 10 millimeter 2-point, and red virtually normal 5 millimeter 2-point discrimination. You can see the gradual progression in all patients, and that has been the case for every patient that we have seen so far. Sensation indeed continues to improve. The mode of action is the hardest to capture. The patients are able to move their face, they're able to smile, they all have regained oral competence. But the problem is that all the scales used for capturing this are used for single-side facial palsy. And therefore, we had to develop our own scale, essentially timing or tracking over time how the function moves from no function, severely impaired, moderately impaired, and normal. And so for each side of the face, we perform these grabs and then put them together. And what we see is that the patient's function plateaus in about 36 months, but reaches approximately 60% of normal. Because our patients are from healthy, disfigured, becoming chronically ill transplant patients, there are associated problems related to that, most notably infections. And they really follow a New England Journal of Medicine publication that deals with solid organ transplant patients. Early on, infections are nosocomial. Later, within the 1 to 6 months, are primarily activations of latent infections. And finally, after 6 months, patients really do well, but do suffer from community-acquired, especially viral infections. The perfusion of the face, you can see on the left side, is really limited before the transplant, and you can see following transplantation how remarkably increased the same facial perfusion is. And this is a phenomenon that we really wanted to study because there's really no organ that's transplanted currently that would look like this. And so with the help of our pathologists, Dr. Leah and Dr. Murphy, we have looked at ingrowth of new vessels into the allograft and indeed found some chimeric tissues where you can identify, based on the blood group type of the patient, vessels that contain elements both of the donor as well as recipient. And that is either sign of rejection, chronic rejection and replacement, or chronic or some sort of a state of balance and tolerance. And we're still looking into this phenomenon. Now, just to remind you, rejection is not something that we in plastic surgery deal with a lot. There are two categories. One is called T-cell mediated, which is typically the early or also acute rejection. It's the one that's most common throughout the life of the patients. And in general, immunosuppressive drugs are very effective in suppressing T-cell mediated rejections. On the other hand, B-cell mediated rejections are typically the late ones, are believed to be component of chronic rejection or the final stage of chronic rejection. B cells are antibody producing, and there is really very difficult treatment for these once they are fully developed. And finally, there's what's called chronic rejection, which we still don't really know what it means in phase. So this is a complicated bar graph, but in essence, you can see that there are a total of 31 rejections, which on average probably ends up being 1 per year per patient. Most of the time, we can treat them with steroid bolus or adjustments of immune suppressive medications, and very, very few were steroid resistant, which are the rejections that require admission of the patient to the hospital and treatment with aggressive measures. The target of rejection are the basal cell membrane stem cells of the keratinocytes, the bulge area of the hair follicle, and endothelium, and that's where you see lymphocytic infiltrates and invasion of the cells and the hair follicles. Antibody-mediated rejection presents a little differently. This is a patient that unfortunately suffered from it within a week after transplant, and you can see remarkably swollen face with almost like angioedema type of picture. And it really required extensive treatment to get this under control. Similarly, if you are trying to document this antibody-mediated rejection, you have to stain histological slides for C4d complement elements. And on the left upper corner, you see the glomerular C4d staining as a control, and then the remaining cuts are from various parts of the skin, and you can really see ubiquitous presence of C4d elements that are lighting up through the slides. For her, we needed not only thymoglobulin repetitively, but also plasmapheresis, steroids, eculizumab, which is anti-complement medication, bortezomib, which is used in multiple myeloma because it blocks B-cell production of antibodies, and alemtuzumab, which is a really broad-range T-cell agent as well. And finally, with that, we were able to get her under control and maintenance immune suppression. Chronic rejection is something that we have seen in 4 patients. It presents in different ways. There are no particular specifics about either one of these patients in terms of number of acute rejection episodes before we saw chronic rejection in terms of sex, age, or initial injury. If you look at them closely, you start to see changes. In this case, little changes on the nose, nasal area, little notching of the right side of the nose, which may be related to mechanical trauma, but also mucosal rejection. In other patients, you can see more pigmentation in the skin and sort of appearance almost like chronic graft versus host disease. And finally, in this patient, you can see along the scar, loss of pigmentation, loss of hair follicles, and just difference in appearance over time. When we looked histologically, the epidermis appears to be thinning. There's a reversal of collagen ratios 1 and 3, and there are also some chronic infiltrates in the deeper epidermal junction. The collagen shift goes from normal to more collagen, which is collagen 3:1 ratio, to more collagen 1, so more fibrotic type of appearance. And to summarize it, we see alterations in hair follicles, we see pleomorphic changes in thickness, vascular hyperplasia, and then endothelial damage, and increased collagen 1 deposition. When we looked at the gene expression, the activation pathways appear to be similar to lupus and systemic lupus and chronic rejection. And finally, the worst chronic rejection that we have seen is the patient who suffered from the beginning from extensive immunological problems. 6 years, she looked great after the transplant, but 6.5 years, she presented with little sloughing and what appeared to be superficial wounds, but ended up being actually full thickness losses of various parts of the allograft, ultimately leading to scarring 3 months later, and the patient is back on a transplant list, as well as unfortunately back on pain medications due to the discomfort that this causes. But nonetheless, we have learned to manage acute rejection. We can probably expect that chronic rejection will occur in pretty much all patients. It's just a matter of time. And we still don't know, and it's humbling to realize that the kidney's half-time is about 10 years, heart and lung about 5. So what is going to be the half-life of facial transplant? We just don't know. These are all the patients before and after. And I would say, in summary, that we still are able to help our patients from fairly limited conventional reconstruction techniques to something that could be considered more of a restorative technique that restores the human face and appearance, including its function, but currently at the cost of immunosuppression for life and likely long-term chronic rejection. Of course, a lot of the patients go on and have been able to walk their daughters down the aisle or got married themselves. This patient, after bilateral hand transplant, even learned to play piano. But it's not an individual effort. It's really a team effort, and I'm proud to show the pictures of the last transplant with the team, at least the team that was there at the end of the case. And with that, I would also want to acknowledge the medical and research team, and I would be happy to answer any questions you may have. Thank you very much.